Currently a master's student at the School of Public Health in Cluj-Napoca, but I'm also a lecturer and a consultant endocrinologist at the university we are currently presenting today. And we're going to talk about a little bit about the medical education in Romania, a little bit about our university, the George Emil Palade University of Medicine, Pharmacy, Science and Technology of Târgu Mureș. Then we're going to present the evaluation of the TBL implementation, which took part in this university, and we're going to finish with some discussion and recommendations. Medical education in Romania, currently we have 13 medical schools throughout the country. 12 are public funded and one is private. And there are 6 traditional schools which were established before the revolution in 1989 and are still the main, let's say, medical education provision in Romania. From 2007, since the joining of the the European Union by our country, all the medical schools have aligned with the EU regulations, and we have a minimum of 5,500 teaching hours for medicine and the 6th year, and we are still in a classic preclinical and clinical pattern with 3 years of preclinical and 3 years of clinical pattern. Regarding the accreditation and regulation of medical schools, in 2005, a Romanian agency for quality assurance in higher education was established, which has power over analyzing and accrediting and also auditing all medical schools and enforcing their curriculum and some activities, which leads to maybe a little less autonomy for the medical schools. Regarding our university, Târgu Mureș is situated in Transylvania, in the center of the country, and it's the main university of the city, a city of 150,000 inhabitants, and is considered one of the trademarks of the city. And you have here a very nice picture during the winter of our university. It was established in 1945, and it is considered one of the 6 traditional medical schools. Nowadays, it has almost 12,000 students and is the only university to provide training in medical training in Hungarian language, which is an ethnic minority in Romania. And for example, in Târgu Mureș represents almost 50% of the population. From 2016, a curricular reform was started and a strategy was proposed. This reform started in 2016 and still ongoing, planned some changes. Regarding the content delivered and regarding especially the curriculum with more attention paid to the index of clinical situation and alignment of all departments with this. And we tried to implement and started to implement a student-centered teaching system and starting to use team-based learning, problem-based learning, and case-based learning. Then they proposed an analogous student evaluation across subjects with and all lines of evaluations of both for Hungarian and Romanian section. They focused on human resource to ensure the adequate number of teachers and to ensure training for these teachers to acquire the appropriate skill mix necessary for implementing the changing in the student-centered teaching system. At the institutional level, they proposed the creation of a special department within the administrative office to focus especially on this curricular reform. So we analyzed and evaluated the team-based learning implementation in this university for the last 4 years. The information sources we used was the official website and all the procedures and reports available. And we conducted some informal interviews with students and staff of this faculty throughout the years. So we're going to take it one step at a time. We start with inputs, and regarding human resources, a commission was formed for the development of the framework for the implementation, and it comprised members from all the faculties, so medicine, pharmacy, and dentistry. And at the beginning, 10 pilot departments volunteered to implement the new teaching method, and one member for each department was made responsible for this implementation. Regarding logistics, we purchased the Dolphin Interactive voting system, and some lecture rooms were selected for TBL sessions, but there were common amphitheaters. At the organizational level, a specific commission was formed, like I mentioned before, which was under the direct rector's supervision, and they have the power to enforce procedures and rule for the implementation of the team-based learning. Regarding the outputs of this implementation, the activities they had throughout the years was to develop a procedure for training session for teaching staff, but it's not mandatory, it's available on demand. A formal training for those pilot departments and for the members who were responsible was available at the beginning and was made by an external specific trainer. And from 2019, a postgraduate course with certification from the Ministry of Education is available, and the end point is certificate in medical education. Then they develop a procedure for team-based learning implementation during lectures. And this procedure starts starting from 2019. Every department has to implement team-based learning during their lecture, but only one session or for every 7 weeks of lectures. So usually 2 sessions per semester. And the team-based learning grades are part of the final evaluation, so they represent a percentage of the final grade of the students. The participants for the first 2 years, only the pilot departments implemented this teaching method, and since beginning with 2019, all departments are implementing. Regarding the outcome impact, on the short term, not very much information is available, but we have the annual report of the Commission, which acknowledges the implementation of the procedure, but we have no specific indicators regarding this implementation. And during our formal and informal interviews with the students, a common theme appeared, and they seem to consider this just another test. And the faculty, so the staff we interviewed, have mixed feelings. Some of them embrace the method and are currently using it for more than the mandatory number of TBL session, and some of them are dismissing it. Not all of them had formal training in this. And medium and long-term outcomes are not yet available. It's only 3 years, let's say, since the beginning of the implementation. In summary, based on the available data, the team-based learning teaching method has been implemented in the Medical School of Târgu Mureș, but without an assessment, an needs assessment, an a priori, or an audit or a continuous evaluation throughout the implementation regarding, for example, the degree of acceptance of the stakeholders, like the end users of this method, which are faculty and students. The formal training is available on demand, but is not mandatory. And there is no clear procedure or a format for TBL session for organizing it or the content apart from general principles. No data is available on the implementation process in different disciplines, and we must say that TBL sessions are used as part of the evaluation and are mandatory with minimum 2 sessions per semester. If we were to discuss the do's and don'ts or the rights and wrongs, we can say that the right thing is that we started the reform. We are trying to focus on the student-centered teaching. Team-based learning has been implemented, and the pilot departments were used at the beginning. The wrongs or the bads or the don'ts can be that team-based learning is mandatory for all disciplines, so all teaching staff must implement it. And the fact that they are used for a final grading The reduced number of sessions per module, so only 2 sessions, which might lead to problems in interpreting the impact of this TBL session. No needs assessment done before starting this implementation. And the fact that faculty and students were not involved during the procedures and the development of the procedure for implementing this team-based learning. And maybe the fact that there's no uniform format for sessions. As a recommendation, we can say maybe we should conduct an audit on the stakeholders' perception with both qualitative or maybe quantitative methods, with in-depth interviews both with students and with teachers. And there's a very nice instrument available, the student assessment instrument, to evaluate their perception and their suggestion, and the results can be used to as process indicators. Maybe the implementation of a team-based learning session for a whole module, so a whole department for the whole semester, and then impact evaluation should be easier. And the formal training for all faculty involved in this teaching method should be provided. And for impact assessment, maybe you should, an indicator can be to assess the student's performance for TBL only modules. For medium term, we can use students' performance at the residency entry exam. And for long term, the change in the quality of teaching and finally in the academic ranking of the university. And the impact evaluation should be placed in the curricular reform strategy. As conclusions, team-based learning is mandatory part of the teaching process at the University of Târgu Mureș. However, it seems to focus only on the first parts of the Bloom taxonomy for teaching, on remembering and understanding, but not on analyzing and creating. And we should try to focus and to find the enablers and the inhibitors which can help us improve this teaching method. And the periodic internal audit at the department and the university level should be mandatory. So I want to thank you very much for your attention and for giving me this opportunity. And I'm open for discussion.
So my name is Gemma Quinn. I'm from the University of Bradford here in the UK. And my presentation is about a study we did looking at postgraduate pharmacy students' views of team-based learning. The work I'm presenting was done by a pharmacy student, Rezwana Akhtar, as part of her final year project in collaboration with me and Dr. Sam McLean here at the University of Bradford. So a brief introduction to team-based learning at Bradford. And as we've just heard, in fact, TBL is an active and collaborative learning pedagogy. And this diagram on the right just summarises the basic steps of team-based learning, the key steps. And it includes a combination of self-study, assessment of the individual, assessment of the team, and application and problem solving, along with immediate feedback. So what did we do at Bradford? Actually, in 2012, we had to reaccredit our Master of Pharmacy programme, which is a 4-year programme. And at that point, we decided that we would implement team-based learning as a whole curriculum approach to our MPharm degree. So it wasn't in one module or one session, it was across the whole 4 years in every module. And so we did a big bang approach. Following that, we received a collaborative award for teaching excellence from Advanced Higher Education in 2018 for the implementation of that curriculum. And this year, we were really pleased that the programme was rated highest in the UK for overall student satisfaction in our national student survey. So we're really confident and have been really pleased with the impact that team-based learning has had on our programme and our students. So the next kind of obvious step was to think about introducing that to our postgraduate pharmacy students. And at the time of this study, I was the programme leader for our postgraduate diploma in clinical pharmacy in secondary care, who are hospital-based pharmacists. So we introduced team-based learning to those students, again, across the curriculum in 2018. Just a bit of background about the programme. So the students on the programme are UK registered pharmacists. They are practicing pharmacists within the UK, within hospitals in our local region. They are usually newly qualified, but the vast majority are within the first 2 years of practice. It's rare to have students who've been around for longer, although we do have some who transfer sectors. The programme is a 2-year part-time programme, and students attend 1 study day per month. The programme also includes work-based assessments to check that students are able to apply their learning to their workplace, because obviously that's the key in training pharmacists. So why did we think team-based learning would be useful for these students? These students are working in multidisciplinary teams from the very first day in practice, and as pharmacists, they're often the only pharmacist on that multidisciplinary team, so they have to be able to hold their own with medics, nurses, physios, the whole rest of the team. They've got to be able to work with them. And we know that there's lots of key skills required, but the key ones that team-based learning we felt would help with were teamwork, the ability to make and justify decisions, the ability to prioritise and negotiate, and the ability to communicate effectively. So to us, really, after having seen the team-based learning approach in the MPharm, it was an obvious choice to get to enroll and to roll it out to our postgraduate taught students. So what were our aims and objectives? So our overall aim was to assess the perceptions of team-based learning in students undertaking the postgraduate diploma in clinical pharmacy secondary care. And it's worth saying, to our knowledge, this team-based learning has not been rolled out to any other postgraduate pharmacy programs in the UK. So we believe we were the first people to do this. So we wanted to collect those perceptions, and we did actually use the team-based learning student assessment instrument that Raluca mentioned in her previous presentation, the TBL SAI, to collect those perceptions. And then we were able to analyse quantitatively and qualitative comments from students as a result of that. And then we wanted to make some recommendations about how TBL could be improved for our postgraduate pharmacy students. It's just a little bit of information about the team-based learning student assessment instrument. It's a validated assessment tool that has 3 subscales, which are outlined here: accountability, preference for lecture or TBL, and student satisfaction. Participants rate a set of statements on a Likert scale from 1 to 5, depending on whether they agree with that particular statement. And there has been work that's previously validated this instrument in pharmacy students. So we were fairly confident that it would be helpful for us in our evaluation of team-based learning. So the 3 subscales, the first subscale is on accountability. That refers to how whether students feel accountable for preparing for their own learning, but also for how they contribute to their peers' learning and other people's learning, so their team contribution. The second subscale looks at the student's preference for lecture or team-based learning, and particularly looks at whether it helps students to recall material and whether they pay more attention in class. And then the final subscale is on student satisfaction, and that is about student preference for team-based learning and also whether they think it is effective in helping them to learn. And the instrument has been developed by Heidi Menenga, and we got permission from her to use this instrument. So what did we do? We developed an online version of the team-based learning SAI, and we asked our students to complete that in a face-to-face setting. So we actually gave them time in the classroom to complete the TBL SAI. They just had to log on with their phones and answer the questions. We did that in 4 face-to-face teaching sessions, and each session had between 20 to 25 students in each group. We obviously recorded the frequency of each response, and there's a specific key for the TBL SAI because some statements are positive and some are negative, and we performed analysis on that data. We also asked students to give us any qualitative thoughts that they had about team-based learning. Now, obviously, it wasn't in-depth qualitative research, it was just literally the odd sentence or 2, but they were still useful, and we got ethical approval for the study. So what were the results? So a little bit of background first about the programme, just to say we have 2 intakes on this programme. So some students start in September and others start in January. So we have a winter and summer intake. At the time of the study, we had 86 students on the programme, and we got a response rate of 70%. So 60 students completed the survey. So this table outlines the characteristics. You will notice immediately that there's a significant split between the female students and male, but that is representative of hospital pharmacy. So hospital pharmacists are more than 70% female, and so this is the split that we see, and also is the split we see on our programme. You'll see that the intake is roughly, it's slightly less students in the summer than the winter, which is always also what we normally see. There were 35 first years and 25 second years contributed, but we did roll out the programme to first and second years at the same time. So the second years hadn't had a previous year of team-based learning on the programme at the time of the study. They'd all started team-based learning at the same time. But 34 students had had some previous experience of team-based learning and 26 had had none. Some of that was from Bradford University. They'd graduated from the M-Pharm and progressed to the diploma, and others had done team-based learning in a different university. So what did the results show? So the overall students did have a preference for team-based learning, and that was reflected in each of the 3 subscales. So just to explain this table, here are the subscales. Because each question was on a Likert scale of 1 to 5, this is the possible range for each subscale. And this here is the neutral score from the key. So this was the middle of the range score that the students could have given, and these are the actual mean scores. So you can see accountability is higher than the neutral, reflecting preference for team-based learning. The preference subscale was higher, but only by a little bit. So I'll come on to that later. And the satisfaction score was also higher for team-based learning than the neutral score. So students did have a positive view of team-based learning. What were our qualitative results? So 14 of our students made some qualitative comments, brief qualitative comments, and we identified some key themes from that. And there were 3 particular themes that we identified that we felt were important. Several students commented on not wanting either all team-based learning or all lectures, but wanting a combination of the 2. And I'll come on to that later because that's quite significant. The other thing that people commented on was about how their experience was very dependent on the other members in their team. And if they didn't have other team members who were engaged and contributing, that reduced the quality of the experience for them. And there were also comments about the effectiveness of team-based learning being dependent on individual learning style. And if you were the sort of student who wanted to sit in your room and study and write out lots of notes, you probably wouldn't find team-based learning very useful. However, remember, these are healthcare professionals who are working in a multidisciplinary team on a day-to-day basis. So I've put some of the actual comments here, the actual quotes. So one student commented that it was definitely better, team-based learning was definitely better in terms of helping to remember stuff. Another said that they gain more knowledge from lecture material at this stage because there's more info from experts. So obviously we have a lot of expert teaching in this diploma. It's very clinical, and some students feel that actually a short didactic session where the expert is imparting all their information is very useful. Another student said, I don't mind team-based learning. I just find it irritating that I have to do most of the teaching myself, which I find very interesting. If you substitute teaching for learning, the students do have to do the learning themselves, unfortunately. And this is the comment about group work, which said that depending on the groups, the people in the group have a huge effect on the experience, but that if everybody contributes, the sessions are more useful and a good learning experience. So what did we think this means? So again, going back to those 3 subscales. So accountability wise, the students did feel accountable. They felt accountable for both their own learning and also their team's learning. They spend time preparing for the sessions, which is really important because, as I said at the beginning, we only have 1 study day a month, and we really have to make the best possible use of that time to get the students to learn and to get the most out of what we've got, the time we've got there. The students also had a slight preference for team-based learning over lectures, and that includes ability to remember material, but they did suggest combining team-based learning and a lecture format together. And we found that students were satisfied with team-based learning as an approach, but they do feel that the composition of the team is important. And one of the comments actually said it would be better if we could self-select, which I will talk about in a minute. It was electronic data collection, and as I've already said, the qualitative data was obviously just 1-line comments. It wasn't in-depth qualitative data. Okay, so what were our conclusions and what recommendations did we make? So overall, postgraduate students did show a preference for team-based learning, which we were pleased with because we felt it very closely reflects what they need to do in practice. And they had this suggestion about including lectures. Now, why this was interesting was because we previously had very similar feedback from our M-Pharm students. So while that's not part of the official team-based learning strategy, we put in for our MPharm students this support session here, which is a lecture-based question and answer session where students, after they've done their self-study, they can come to the support session if they want to. The lecturer can talk through any complex concepts, and the students get the chance to ask questions and query anything that they don't understand before they do their individual test. So we'd previously felt that would not be possible on the postgraduate programme because the students are only there for one day. But obviously now we all can use Zoom, we all can use Teams, we can use anything to have a session before the study day, just to give students that chance to ask those questions and get that clarification before they do their individual test. So student satisfaction that was focused around team selection, and whilst we agree it's important, we definitely don't agree that you should be able to self-select, particularly given these students' profession where they're working in a multidisciplinary team with people they don't choose, with people they may not like, with people they may not agree with. So it's actually really key that they're able to express their opinions and influence others in decisions as an individual pharmacist in a team. So, but we think we probably do need to do a bit of work to help students to understand why it's so important that they don't self-select their teams and to understand the value of having these mixed teams. And so the next thing we need to do is to compare this data. So we actually have a very similar data set for our undergraduate students, and we need to do a formal comparison between the two to see if there's any major differences. We'd like to do a bit more in-depth qualitative data collection because obviously as health professionals in practice, we'd really like to know what their views are on the best ways for them to learn. And we also want to think about the ways that we can help the students to understand the actual learning process. So going back to that comment about a student feeling they're teaching them, that they have to do the teaching themselves. You know, nobody can learn for students, they have to learn for themselves. So it's getting them to develop an understanding of the process and why they have to go through these things. They have to do it themselves. So that was our study. These are the references. And thank you very much for listening. These are our contact details if anybody wants to get in touch with us. As you probably gathered, Bradford is a kind of team-based learning huge fan. We love it and we think we do it really well. So we'd be really keen to collaborate with anybody who is interested in team-based learning or learning more about the process or doing some further research. Okay, thank you.
Introduce myself first. My name is Nuzulul Putri from Indonesia. I'm an assistant professor in Department of Health Policy and in the Faculty of Public Health Universitas Airlangga. I would like to share our experience in conducting team-based learning for our main course in the public health program, which is the health program planning for public health program, and how it happens in this kind of situation of COVID-19. Well, this is the profile of our Bachelor Public Health. The Public Health in Indonesia consists of 3 levels. It's Bachelor, Master, and the Doctorate. And what I want to share now is the Bachelor of the Public Health. It's 4 years undergraduate degree program with core competency that you can see in the screen that we have 8 core competency that most of them always ask us to come in socialize with the community, which is kind of is very difficult to do in this kind of situation with COVID-19 confinement in Indonesia. And for the Bachelor of Public Health itself, the curriculum is standardized in nationwide. So Universitas Airlangga is one of the main university in Indonesia, and it is also the prominent faculty of public health. So we try to also accommodate what to educate small health institution that also like to replicate the Bachelor of Public Health itself, and the curriculum itself is standardized in national because there are so much diversity in the Bachelor of Public Health Education in Indonesia. And then as we know that one of the core competency is for the Bachelor of Public Health Indonesia is they have to be able to design a public health program. One of the main subject is the public health program planning and evaluation course. So what we have to in Indonesia, we commonly use case-based, interdisciplinary health workforce and community, and also we use team-based learning. For the case-based itself, we try to relate the responsibility of the public health center as, or commonly we call it as puskesmas. This kind of a primary care center in Indonesia, that they not only have responsibility to treat the sick, the illness of to treat or cure the patient, but also try to promote and prevent disease in the community. So the profile of Bachelor of Public Health undergraduate student, after they graduate from the Bachelor of Public Education, they will be able to become one of the health programmer in this health facility. And for that reason, we try to accommodate the case by accommodate the responsibility of the puskesmas, and also since in the that owned by the government, the planning and the budgeting system is regulated in nation. So that's why this course is always case-based with the current issue and also the current regulation in public health planning and the budgeting. And for the interdisciplinary health workforce and community, we try to also accommodate that health program planning is not always evaluation only, as epidemiology, health promotion, nutrition. That's why the team teaching is not only from the administration department. And then we also ask some practitioners in the puskesmas to be the visiting lecturer, and also to assist the understand well how to conduct health program planning and evaluation. And then we also coordinate with the healthcare in the primary healthcare and also the health workers in the puskesmas. For this course, we also try to use team-based learning. Actually, at first time we try to use the team-based learning. The reason is because we have so big number of students in one class. Each semester we will have 255 students, and it's divided into 4 classes. So actually one class will have 70 students, and it's to ensure that all of the students will understand well step by step in standing in conducting in public health planning, and to use team-based learning for condition of the COVID-19 Indonesia. We have very high trends in confinement, and right now we already at least 2 semesters doing this course online. So it's very hard for us, for the teacher also, the student also, and the practitioner to conduct this course, because like we know that the previously we should deal with the community, we should come to the community, but right now it can be done because of the COVID-19 transmission. So let me share our course structure and any challenge that we face in conducting this course during this COVID-19 confinement in Indonesia. Well, the course structure, let me start with the team composition. Before the study at home policy of due to the COVID-19, each class will be divided into 8 groups, and there will be 8 to 9 students in each group that randomly selected or grouped by the team teaching the lecture, and then it will be assessed by one health programmer from Puskesmas. Each group will be also always have regular interaction, not only with the lecture in the class, but also they will come to the community and the health facility. Because of the COVID-19 confinement, during the study at home, we try to redesign our team-based learning, and also, of course, the team composition. The team composition is still the same for the number. What we done with the grouping is we try to group the student based on their regional base, because the public health program will be specifically actually in the regulation that it will be specific only for its region. So it's kind of difference in conducting this cannot we cannot accommodate the regulation that the health program will be only for the specific population based on the region. So we try to group the student based on their home region. Maybe we hope that they can have easier access to get information during this COVID-19 confinement. And then this is the our team-based learning structure. We divide it into 3 phases. Phase 1 is preparatory, and then the application, and the last one is the evaluation. The phase at the first week of the course. Actually, the course consists of 14 weeks. So in each week we already set some learning outcome and the method that we try to share the material, and then in the first week we try to introduce the overview of the health program planning, and also understand them what will we do during these 14 weeks, and the outcome that expected after they finish the course. And then we use the workshop. Of course, it's online. We try to share a tutorial video first, and then lecturing from practitioner. We give a reflective feedback based on interaction in the video conference, and then we ask them to always update with information search, because the regulation will always changing, and it also happen in this kind of in this meantime quiz for the individual. And then for the phase 2 in the application, we use the TBL, and we divided them, we grouped them into team, and then we give them a case of problems in 4 areas of health facility in Puskesmas Indonesia: maternal health, communicable disease, health promotion, and nutrition. So each team will have different areas that will be solved, and there will be they will be plan a plan of action of its solution. And then for the application itself, we try to do in class and on class activity, and also in the end we ask them to disseminate what they have done. In class activity and on class activity means that it face-to-face video conference or not, because we already ask our students that the data collection for this situational analysis or in every step in this course must be conduct in online method. So there is no interaction in offline method to the puskesmas. In class activity, we try to have a reflexive feedback and immediate feedback through a discussion in breakout room, working paper fulfillment, peer evaluation, etc. And then the out class activity, we ask them to do step-by-step of health program planning cycle from the data collection until the evaluation. And then in each week, and also in the last week, in the 14th week, we ask them to disseminate what they have done, and we ask them, we try to use more variable, more varied media, like such as video, e-poster, paper, and that commonly we do not use in the previous before this pandemic. And then the evaluation of this course, we try to see the individual development through the quiz, meet, and final exam. And then the team, we ask them to use to present the paperwork, and also the ask them to give a peer evaluation among their members.
Very much. I would like to thank you for the opportunity to participate in this conference. And I would like to say that currently I'm a student in the Department of Public Health. And today I'm going to talk about the public health workforce in Romania. So firstly, I would like to start off with a little bit of background of what does it mean to be a public health specialist, and what are their jobs in relating to the healthcare sector. And I would like to say that according to a study made in 2011, public health professionals play a central and decisive role in improving access and quality healthcare for the populations. And public health specialists provide, firstly, an essential services that promote and prevent disease occurrence. And they also engage themselves in scientific research, planning and evaluation of different health programs, and they also engage themselves in advising and developing policy brief and decision making. And they also perform the implementation of population-based health promotion and prevention. And I would like to emphasize that a multidisciplinary approach is essential in the management of public health problems and the interprofessional collaborations, because the work of public health is mostly important because, firstly, the public health initiatives determine people's daily lives in every part of the world. And also the work of public health specialists focuses on broad issues that can affect the health, the strength, and the vitality of individuals and populations. Moving forward to the case of Romania, I would like to emphasize that unfortunately, at the moment, there is a major lack of trained, employed, and retained public health physicians across our country. And this is because of several issues. Firstly, that public health physicians have unfortunately limited opportunities to work in the Romanian local public health authorities, because the public health authorities tend to be overcrowded with physicians, not public health specialists, and the physicians tend to overload the work that public health physicians need to do in our country. And also there were significant disparities in training to obtain certain public health positions. And because of these issues, me and my colleagues from the Department of Public Health, Mr. Marius Ungureanu and Mrs. Alina Forai, developed a policy brief that has an aim to provide an overview of the Romanian public health workforce and identified potential solutions to address the identified challenges. And regarding the methods we used for our policy brief, I would like to start off by saying that the data on the number of residents in public health workforce was taken from the Romanian Institute of Statistics, and the analysis was conducted based on the available data for the years between 2019 and 2011, taken from the activity of the healthcare institutions. This is basically a report that it's providing the exact number of physicians for each of these specialties in the healthcare. And the analyzed data includes the number of physicians and residents in public health and management, their gender, their special distribution in Romania. And I would like to say that unfortunately data was partially missing for the year 2014. Our findings are focusing on the following results, and as you can see at the first glance in the first graph, you can see that the number of public health professionals fluctuated a lot between the years of 2009 and 2018. And their number has had a significant decrease in starting from 2009 to 2012. And on the other hand, from 2012 to 2018, there was a slight increase in the number of specialists, maybe because the public health field was tending to become more popular in Romania, but there is still a major lack of public health physicians nationally. And in the second graphs, you can see that each year more than 3/5 of all the public health physicians were women, which shows a tendency of feminization. And this is very popular in other specialties in Romania too. And one of the most important findings of the policy brief was that half of the countries in Romania do not have health professionals specialized in public health and management. Across Romania, we have 41 counties, and half of them do not have public health specialists. The majority of the public health workforce is concentrated in big academic cities like Cluj, Bucharest, Iași, or Timișoara, and the other cities are left outside, unfortunately. Regarding the discussions, I would like to emphasize that in order to strengthen the development of future public health services and capacities, we, as you can saw in the previous slides, complied and analyzed the current trends of the health workforce in public health and management from Romania. And according to the results of our policy brief, we found out some major limitations. The first of them being that higher education institutions are heavily treated towards the production of physicians and nurses compared to public health professionals. At the moment, the Department of Public Health is the only institution which is providing support and assistance for future public health specialists in Romania. And in our opinion, higher education institutions need to increase the type and range of training provided for the ones who want to pursue a career in the public health field. Also, the fragmentation of data on the public health workforce and the distribution of responsibilities across national and local agencies limited a lot the capacity of Romania to firstly collect and then comply and also analyze workforce data. And as I mentioned before, one of the major problems we encountered in when we developed our policy brief was the lack and poor quality of data. And as I said, the data from the National Institute of Statistics was partially missing in the year of 2014. Regarding the conclusions, we can draw now. We want to emphasize that there is urgent measures. They need to be urgent measures in order to firstly guide and accelerate and improve actions across Romania to employ, retain, and motivate public health specialists in our country. And for this, we are suggesting some steps for making public health more popular. And the first one is that there is an urgent need of assessment of public health workforce shortages. Second, we need to focus ourselves on education, continuous training, and evaluation of public health activities. And we should also assure adequate delivery and implementation of public health services and activities. And lastly, to have a continuous development and investment in the public health workforce in Romania. These are our references, and I thank you very much for the presentation.